Hi there. My name's Rebecca. I'm a pharmacist, and I work with my colleague Linda Briant, who'll be coming up in a moment, on a large-scale programme of care looking at the management of type 2 diabetes in primary care. We were part of a large-scale programme called the Diabetes Modernisation Initiative that took place across Lambeth and Southwark CCGs and involved everybody that was involved with diabetes care, with putting the patient at the heart of it. So we worked across our 2 large acute trusts, our community service providers, and 90 GP practices. When we set up the programme, we developed a case for change. We looked around us and saw that the services that we were providing for diabetes were not good. We chose to measure an HbA1c of 64 millimoles per mole, or in the old language 8%, and we chose to look at the total population that was controlled. So that's without exceptions if you are living in the QoF world, the GP world. So this is a real reflection of how glucose is controlled in our population. And when we looked at that, we noticed that we were doing pretty badly, being in the bottom quarter for both London and nationally for CCGs. We also noticed a really wide variation. So some practices were doing really well and controlling over 80% of their population with an HbA1c less than 8%. But in the poorer performing practices, this dropped to half that amount. We also weren't very good practices weren't very good at completing the National Diabetes Audit, with less than half of practices actually doing that before we started. And from that information, we know that lower than the average percentage of people received all 9 care processes. So what we knew at the start of this programme, or this piece of work, was that we had quite a long way to go. And we also chose to do this bit of work at a time of unprecedented change and turmoil in the NHS, when PCTs ended, they became clusters or CCGs, and clinical commissioning separated from contracting for primary care. So we set ourselves quite a hard task. I'm going to talk about one part of the diabetes modernisation scheme, on a modernisation programme, and it's focused in primary care. And we chose primary care because we recognise that most care for people with diabetes happens in primary care. We used the patient voice. We worked with our patient group to build momentum for change. And frankly, if patients are telling you as a group that care isn't good enough, you need to do something about it. We chose to focus on a few indicators that all could get behind, and we linked it as far as we could with other contracts. So the Quality and Outcomes Framework in primary care, and locally, many of our practices had a local GP contract called a Personal Medical Service contract, and there were diabetes-related KPIs within those, key performance indicators. We also knew we needed to focus on system-wide change to build sustainability. So what was our approach? The previous speaker talked about 5 pillars. We had 7 pillars, and we had a really strong foundation. I think it's important to start from the bottom up. I've already told you that we knew we were doing poorly locally, so we used our local needs assessment and supplemented that with a strong patient voice telling us that we needed something to change. And then we developed a programme that encompassed 7 different pillars. It was based around a scheme, an incentive scheme for primary care. It was associated with a very small amount of money. So all the practices in the CCG could earn up to £50,000 in the first year, which increased to £100,000 in the second year. We focus a lot on practice-based systems and processes of care, and we developed local IT searches that we spread out to all general practice, so that practice staff, both managers and clinical staff, could see how they were performing and which cohorts of patients they should concentrate on. We shared the data that we collected frequently with our colleagues and helped them realise how they could improve diabetes care for their practice population. And often by breaking something down into quite small steps, people felt that this was achievable if you break it down to a cohort of a small number of patients. We developed some practical tools and some guidelines, and then we shared those through learning events, which were very well attended. And we also supplemented that by change champions, so local people interested and providing good diabetes care, supporting their colleagues. We set up this programme of care, and it was this incentive scheme, and it ran for 2 years between April 2012 and March 2014. And I wanted to share some of the achievements with you. And what I feel really proud about is that these are large-scale achievements across a large population. During this time period, the population prevalence increased. What you'll notice is that the gap between the population we expected to have with diabetes and those that we detected has decreased, because we're finding more people with diabetes. So we're actively case finding. You'll notice there is a steep drop between 2011-12 and 2012-13 because there was a list cleaning exercise with the practices. So what we know is that those people that are on the register now are really people that live in Lambeth and Southwark and have diabetes. So now, if you're a patient with diabetes in Lambeth and Southwark, you have a 4 in 5 chance of being on a practice register, where before the programme you had a 3 in 5 chance. We focused on looking at care processes because we knew from the National Diabetes Audit data that we did quite poorly in this area. So we set up local searches to measure the 9 care processes, and so this data is not quite the same as that in the National Diabetes Audit. But at the beginning of the programme, a third of people received all 9 care processes, and by 2 years later, almost half of them were receiving all 9 care processes. And what we saw was the greatest improvement in the measurement of kidney function, foot checks and smoking status, which is where we knew that we didn't do very well before. So we saw the biggest increases where we needed to see them. Interestingly to note that in QiC for 13-14, measurement of weight for diabetes dropped out of QiC, and we noticed that there was a reduction in recording weight. So I think it's really important for the future to recognise, if we're keen to keep promoting the 9 care processes, when changes in QiC happen, we have to work extra hard to make sure that performance continues. So we've looked at the processes of care, and now I want to look at some outcome data. We don't have hard outcome data about amputations, as an example, but we do have surrogate outcome data around the measures of biological control. So this is showing you the number of people that were controlled. In the orange bar is Lambeth, the grey is Southwark, the yellow is the combined Lambeth and Southwark measure, and the blue bar is England. So what you'll notice over this time is that when we started the programme of work, we were significantly below the national average. And by the end of the programme of work, we were just creeping up and just over the national average. And this was against a background of a huge number of additional patients on the register. So that we knew in that 2 years that over 2,000 people, additional people, were controlled with an HbA1c of less than 64 millimoles per mole. We were really interested in looking at variation because we didn't only want to increase the average, we wanted to make sure that the variation decreased. So this shows you, at the beginning of the programme, a large cluster of smaller practices at the bottom left-hand end, which are all clustered around the lower national quartile performance. And we wanted to shift those practices up and along. So by the end of the programme, the data here shows you that same number has vastly reduced. So we achieved what we set out to do. Not only did we improve the blood glucose control, but we also looked at other biological measures. Here I'm showing you data about blood pressure, the tighter blood pressure control of less than 140/80. And you'll notice with this that we were significantly below the England average when we set out, and by the end of the programme we are close to or above the national average. I'm very proud of this because I think it's a hard thing to do, and I think for a long time practices have struggled, and the numbers here are really large. So it's almost 5,000 additional patients had a blood pressure that was less than 140/80, which we know will make a significant difference to their life going forward. We also looked at cholesterol less than 5 millimoles per mole, We were surprised to see, actually, because we didn't focus that much on this particular measure, that we started out around the England average, but by the end of the programme we were above the England average. And I really want to be clear, with all these, we are using the true register control without exceptions. So this will always look less advantageous. The numbers are lower than if you were looking at QoF, pure QoF, if you look at GP data. So I've told you about the process, improving the process of care. I've showed you how the biological outcomes have also improved. But what I also wanted to let you know is we did a large programme of work working with patients and enabling clinicians and patients to work more collaboratively together. At the beginning of the programme, we didn't recognise collaborative care planning within any of the GP registers, and although people felt that they did it, we didn't have a standard way of approaching it. So through this programme of work, we set out a training programme, defined what collaborative care planning would be, had a lot of training and support using patients, and in the first year, 17% of our patients with diabetes had a collaborative care plan agreed between themselves and their nurse or GP in primary care. And by the end of the programme, that rose to almost 40%, with large numbers having had a review from one year to the next. So in summary for me, for the outcomes, what I'm really pleased and proud about is the large number of people with diabetes whose lives have been improved by this programme of work. From when we started out the programme, you're much more likely to be detected now if you have got diabetes and you live in Lambeth and Southwark. And once you have been recognised as having diabetes, you're much more likely to have a systematic approach to your care as identified by the 9 care processes. And you're also much more likely to have sat down and discussed your goals and what you'd like to achieve with your GP or your practice nurse and agreed how you're going to work through those goals. And last but absolutely not least, you're much more likely to have better biological control. I'd just like to hand over to Linda very briefly to talk about how this programme of work has been continued in our local health economy.
Well, it's really just to sort of say thank you, Rebecca, and I've got the very easy slide, which is just to say that, as we said, this was one of 4 work streams within the Diabetes Modernisation Initiative. That programme came to an end in May last year, but the work continues. There is a website, which is the DMI Legacy website, which you have the details there, and all the programmes of work and all the resources. So pinch with pride, use it, take it. If you need to contact me, I am now working with the Health Innovation Network, which is the South London AHSN, and here's our website. We're already working with the information we had from the Diabetes Modernisation Initiative, and we've developed a structured education toolkit from the learning. We're developing new resources, so please, if you want any information about the DMI or the Health Innovation Network and what we're taking work and how we're taking work forward, then I'm available and you can get me on the second website. Okay, that's us.